We move on with the next presentation. Thank you, Dr. Kapoor. Our second speaker is Dr. S.C. Govind, Senior Consultant Cardiologist at the Narayana Institute of Cardiac Sciences from Bengaluru, and he'll be speaking for the next 11 minutes on thrombosed prosthetic valve. Dr. Govind, please.
Very late good afternoon to all of you. With increasing use of the mechanical valves, the incidence of thrombosed prosthetic valves and the way we see them will be much more as the years go by. So let's look at a few patients as to how they present and how it matters to us when we are in the critical care. When you look at the prosthetic valve, the mechanical prosthetic valve, the thrombus is the one which is the commonest cause, which is going to cause dysfunction. It can present in variable ways. It can be a small thrombus, not visible, and patient can be asymptomatic, or it can be a slightly bigger thrombus, but wherein you have a little bit of higher gradients during routine echo, or it can be in the critical care in the emergency when patients suddenly come with sudden onset of breathlessness, and they can come with acute heart failure, cardiogenic shock, and they can also come with thromboembolic episodes. Now, a full assessment of prosthetic valve needs to be done. One can have a rough protocol wherein we look at the rhythm, whether the patient is in sinus or in atrial fibrillation. And the first line modality of imaging is going to be transthoracic echo. And then we have the TE as the supportive investigation. And then 3D TE also provides us incremental value. We'll be looking at the motion of the leaflets, whether they are reduced in mobility, whether there's a presence of thrombus, and also looking at the Doppler parameters, especially the gradients, and then the various other parameters which I've listed out here. And also we'll be looking at the left atrial, left ventricular size, the ejection fraction, which this also matters in terms of the risk factors for developing a thrombus, and also presence of pH as a sequelae, and also a pannus, which can lead to a condition where you can have a thrombus, pannus thrombus also. So in terms of the thrombus, how does it look like? It's going to be less echo dense. It will look a little soft. The disc movement is always abnormal. That's the characteristic sign. And there's always going to be an attachment to one of the leaflets. And then you have a mass which frequently extends into the atria. And the thrombus as such can be quite mobile sometimes, and then can be quite large mass also in terms of thrombus burden. So let's look at a few patients. There's a patient who underwent bileaflet mitral prosthesis, mechanical prosthesis, was doing fine. And then after a period of around 7 months, came with acute breathlessness, and you can see that one disc is not moving here, and the other one is the one which is providing some inflow into the left ventricle, and you can see that the gradients have gone up. And then this is a very classical case of how a bileaflet with thrombus can come. And the thrombus is not easily visualized in transthoracic echo. So what we have to do is we have to use the transesophageal echo, which sort of gives us clarity and confirmation. And here you can see that the one disc is not moving at all, and a little bit of zooming shows that there's a layering of thrombus which starts from right here and then extends all the way down and goes into the left atrial appendage. And you can see in the transgastric that it is not moving. So this is confirmatory, and this is how the diagnosis is made when the transthoracic cannot provide us much information. So this is an example of a patient with acute breathlessness, thrombus confirmed, one disc mobile, no MR, and successful thrombolysis, and the patient did well. Now patient 2, according to the sister here, he had stopped taking medicines for about 2 to 3 weeks, and then he came with acute left ventricular failure. He was in all cardiogenic shock, and you can see here that the valve is not hardly moving here, hardly opening here, and also look at a thrombus which you can clearly visualize in the left atrium, and in the fourth chamber here you can see that it's extending up to the left atrial appendage. And also the additional thing what he has also got is the left ventricle, which is severely dysfunctional. So this is a very bad scenario, and again, this is an image of how the flow is happening and the gradients increase. So here the patient was taken up for surgery despite the high risk explained to the patient. The patient did well. So an example of a tilting disc with a thrombus and a different management approach. Patient 3, you can have a patient presenting with mitral regurgitations. So here you have a regurgitation which is usually central, but it can be eccentric also. And again, transesophageal echo is the one which is confirmatory and provides us the presence of thrombus here. You can easily see that the thrombus is seen here, and a little close-up also shows that it is slightly mobile. So an example of a patient with the bileaflet valve with mitral regurgitation. And this patient underwent thrombolysis, did well. Patient 4 is a little complicated, more complex. This patient had Marfan syndrome. He had Bentall, and this is the conduit which you see here, and this was the aortic valve, mechanical aortic valve here, and this was okay, not an issue here at all. But the patient basically came with occlusion of one of the discs here. He also had an associated mitral valve replacement for mitral valve prolapse. And this was the one which brought him to the emergency care. And you can see that one disc is not moving, and this is where the flow is happening. But in addition to that, you can see that there's a small regurgitation which is coming anteriorly. And transthoracic, as far as the fourth chamber is concerned, not really contributory. Again, just confirming that the flow was restricted and the gradients high. But it was in the transesophageal that one gets a little more insight. You can see that there's a small area here. This is the one which is causing the problem, the thrombus which is seen here. And this was a little layer and not really extending into the left atrial appendage. In addition to that, you can see that there is a significant paravalvular leak also, which was also present. And when you put in 3DT, it gives you some additional value to what you're actually seeing. So here you can see that one disc is totally stuck, not moving at all here, and you find that there are small chunks of the thrombus which are extending in a patchy way here, and then you can find that on slight moving of the data set, what looked like a small paravalvular leak here. This is the left atrial appendage, your aortic valve is here, and what looked like suspiciously like a small paravalvular leak. So this is a little bit of a complex scenario, and the color shows two jets here, one coming through the orifice here, and then one coming at the area where beyond the sewing ring here. This is the paravalvular leak here. So this patient underwent thrombolysis. For some reason, the cardiologist preferred tenecteplase, which did not work, and then he was put on streptokinase, and he started to improve. Gradients started to gradually improve. But then during the infusion, he developed an embolic episode, and in the middle of the night, he had to undergo an emergency removal of the clot from the brain as he developed hemiparesis. The interventional neurologist came and did that, and after that, further thrombolysis was halted, and then this patient was offered surgery. It was a high-risk surgery. It was explained to him. I was not very keen on it, and presently the patient is on follow-up, very limited activity, but so far he seems to be stable. So sometimes dilemmas and problems can occur in these ways. And lastly, one more patient. This patient underwent, again, he had a bicuspid aortic valve, and then he also underwent a Bentall because of aortopathy here. He had a large ascending aorta, and this was about 4 or 5 years back. And for about 2 weeks, he started to develop breathlessness, and then it suddenly accelerated over the last couple of days. And you can see here that there's a lot of turbulence at the aortic valve here, and then you can see that very high gradients, a mean gradient of almost around 57 here. So severe obstruction. And again, the transthoracic is not very contributory in terms of the aortic valve, and he underwent a TE, and then a TE showed a soft tissue shadow here and a density which is suggestive of a thrombus here. And you can also see that the leaflet movements are also not good, and then the flow also is sort of obstructed in one orifice, and there's turbulence over there. And then if one switches on to the 3DT, you can easily make out that this area, this irregular shaggy area, is a lot of thrombus which is causing the obstruction, and this was what his problem was. And this patient also underwent thrombolysis, and so far he's okay. So to conclude, presence of prosthetic valve thrombus can have variable clinical presentations. They can present with breathlessness, hemodynamic instability, they can present with embolic episodes. So what is important to note is that whenever they come with it, with a history of mechanical valve, one has to compare the gradient. Has the gradient increased from baseline or from an established normal value, and immediately the prosthetic valve dysfunction is confirmed, and then it is correlated. And then we also have to look into the background, how recent was the onset. More recent the onset, it's more likely to be a thrombus. And also we have to look into the drug compliance, and then the INRs and the other risk factors which go into it. And also we have to keep in mind that it is the mitral processes which is usually affected, more commoner than the aortic processes. And just to summarize here, transthoracic echo is a first-line modality, and it may not be contributory in all, but if the clinical suspicion is high and if one is not able to have a confirmed diagnosis, TE should be considered, And if one has a 3D facility, this has incremental value, as you saw from one of the patients. And also, fluoroscopy is an additional investigation which can be used to increase the sensitivity and confirmation of the diagnosis. Management of thrombolysis and surgical intervention, that's a different topic altogether. I will not go into that. So with this, I'd like to end. Thank you for the patient hearing.
Thank you for showing some very nice cases. I think it is so common that, believe me, we see almost 1 or 2 cases every month. The reason being, the group we are treating is what we call as a central government health services person. They are illiterate, some of them are coming from villages, economically low. They don't know, they stop the treatment, something happens, and at least 1 or 2 cases they come every month. And what we do, normally our policy, we do a transthoracic as you said. And some of our intervention cardio, what they do as soon as you find the symptoms, high gradients, everything, they straight away put on a thrombolytic therapy. If there is a doubt, then they do a fluoroscopy. But very rarely, although we have told them, but very rarely they ask their case for a transesophageal. They are very happy by getting a transthoracic diagnosis, fluoroscopy, and putting them on that therapy. But very good cases.
Yeah, that's very good case. In fact, similar to I come from a public hospital, so we encounter this problem very, very often. There are two important things. One would be a comment. There was a time about 3 years ago when in 1 month I encountered 6 cases of stuck valves, primarily because of valve thrombosis. So I went to my surgeon and said, you give these patients to me, and I thought that it was obligatory on part of us as cardiologists to give our numbers for this particular purpose. So now I make it, I tell my patients who have prosthetic valves that I'm going to ask you just one question: what is your INR and what is the dose of the oral anticoagulant you're taking? There will be no more talks. Yeah. If it is, I will just tell you to increase or decrease the dose or continue the dose. And that's been phenomenally helpful. I get calls from Bhuj in Gujarat because a lot of these central forces guys, they go from west to bang across the extreme east of the country. So that's a very, very pertinent and very well discussed topic. Yeah. Another thing is patient number 4. I got a patient actually who was carrying number of lytics. He came from Bihar. He was having recurrent valve thrombosis. So what you said is absolutely fine. There are the different prosthetic valves have different thrombogenic rates and different propensities for thrombosis. So, and it is again well documented that you could actually change the type of valve. That is true for an emergent situation like you were faced. But this guy came in an interval. He came between 2 thrombotic episodes. So the guidelines were quite silent over there. What would you do in such a situation?
This patient did not come with an embolic episode.
No, not with an embolic episode. He developed an embolic episode during your patient.
Yeah, the guidelines say that if there is an embolic episode, surgery would be a better option.
Embolic episode, no, I'm not saying. I'm saying recurrent thrombosis, if a person has, despite, and every time, there were at least 4 or 5 times that he had thrombosis and was given a lytic. Now he comes during the interval. If he comes during an acute episode, the guidelines are clear. You go ahead and change the valve because he's been having recurrent thrombosis. But if he comes during an interval, you're in a dilemma. Yeah, the recurrence may not happen for many years or may happen the very next day.
There's no easy answer for that.
Thank you very much, Chairpersons. We'll move on to the next presentation. Thank you, Dr. Govind.